Hello everyone, welcome back to my channel of lively life snippets. I hope life treats you well. Today I made my PRP case report into a video. My case report was derived from a patient whom I met during my 1-week respiratory (MTAC) attachment with my preceptor. The title is a case of poor inhaler techniques in COPD patient, choices of inhaler. Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team. This video is a sample of case reports that I had done during my Provisionally Registered Pharmacist (PRP) training in Malaysia.
The format of case report heavily depended on your preceptor. Kindly consult him or her. For my case, no abstract or introduction was needed. So, let's proceed to case presentation. An 83-year-old Malay man was referred to Respiratory Medication Therapy Adherence Clinic on the 19th of March 27 when he attended his follow-up. He had underlying COPD and hypertension. He was an ex-smoker and stopped for 10 years. He had no known drug or food allergy. He was prescribed Respimat tiotropium 5 mcg once daily, Everhaler salmeterol 25 mcg dose, fluticasone propionate 125 mcg dose 2 puffs twice daily, metered dose inhaler MDI, salbutamol 200 mcg when required, theophylline long-acting tablets 250 mg once daily, losartan tablets 50 mg once daily and aspirin tablets 75 mg every morning. Patient was counseled to use aerochamber with all inhalers. Patient received influenza vaccine on the 20th of December 2018 and pneumococcal vaccine on the 2nd of January 2019. From February 2019 to May 2019, patient had 3 exacerbations with one of them requiring hospitalization from the 19th of March 14 to the 19th of March 15. Upon discharge, MDI pretropium 40 mcg 3 times a day was changed to Respimat tiotropium 5 microgram once daily. Throughout the 3 RMTAC visits on the 19th of March 27, the 19th of April 18 and the 19th of May 16, MDI or Everhaler with aerochamber techniques was satisfactory. He actuated 2 puffs at once. However, his Respimat techniques with aerochamber was poor. He was unsure of how to install and prime Respimat for all visits. On the second visit, he did not turn the Respimat before dose actuation. On the third visit, he inhaled too fast with whistle sound heard. Sometimes, he used inhalers without aerochamber. From February 2019 to May 2019, patient had 3 exacerbations with one of them requiring hospitalization from the 19th of March 14 to the 19th of March 15. Upon discharge, MDI pretropium 40 micrograms 3 times a day was changed to Respimat tiotropium 5 mcg once daily. Throughout the 3 RMTAC visits on the 19th of March 27, the 19th of April 18 and the 19th of May 16, MDI or Everhaler with aerochamber techniques was satisfactory. He actuated 2 puffs at once. However, his Respimat techniques with aerochamber was poor. He was unsure of how to install and prime Respimat for all visits. On the second visit, he did not turn the Respimat before dose actuation. On the third visit, he inhaled too fast with whistle sound heard. Sometimes, he used inhalers without aerochamber.
The next section is discussion. Treatment goals of COPD are to reduce symptoms and future risk of exacerbations. Observational studies showed a significant relationship between COPD symptom control and poor inhaler use. More than 2/3 of patients make more than one error in using any inhalers. This matches our case. Thus, patients who cannot master an inhaler may require switch to suitable device. The choice of inhaler is dependent on patient's ability and preference, prescriber, cost and access. After an exacerbation leading to hospitalization, MDI pretropium was switched to Respimat tiotropium. This is in line with Global Initiative for Chronic Obstructive Lung Disease (GOLD) 2019 recommendation that LAMA are preferred over short-acting agents. According to the follow-up algorithm in GOLD 2019 report, our patient is currently on long-acting beta-2 agonists (LABA) and long-acting antimuscarinic antagonists (LAMA) and inhaled corticosteroids (ICS). Exacerbation risk reduction is more relevant to this case. According to Gold 2019 report, patients with at least 2 moderate exacerbations every year or at least 1 severe exacerbation needing hospitalization in the prior year, LABA, ICS may be suitable at lower blood eosinophil counts threshold at least 100 cells per microliter, because patients with higher exacerbation frequency or severity more likely to benefit from ICS. This probably matches our patient depending on his eosinophil counts. Inhaler techniques and compliance are not satisfactory and need to be addressed. Switching Respimat to Breezala should be considered. Compliance can be addressed by using phone alarm, medication charts, incorporating into daily routines such as after brushing teeth. If these turn out not effective, family members should be involved to remind patient. In vitro and in silico studies comparing Respimat, Breezala, Genuair and Ellipta inhalers which are indicated for COPD showed that Respimat inhaler results in least particles deposit in the moth throat model and most particles reaching every regions of the simulation lung model. In terms of satisfaction, randomized, multi-center, open-label and crossover INHALATOR study in 140 patients in Brazil showed greater satisfaction and preference with Breezala 57.1% over Respimat 30.1%, p equal to 0.001 and p less than 0.001 respectively. Difficulties reported for Respimat involve handling of device while for Breezala involve inserting capsule into device. Another head-to-head comparison study between Respimat and Breezala conducted by O'Hagan et al. On 240 COPD patients showed that majority of patients preferred Breezala over Respimat 56% versus 44% respectively. Breezala was rated statistically superior for 20 out of 22 handling-related attributes. Significantly more patients are confident that they receive a full dose of Breezala and opine that Breezala is easier to learn and use compared to Respimat. The more intuitive a device is to use, the less time will be used on learning and more likely it will be used correctly by patients with less errors. This was supported by INHALATOR study 2. Patient found Breezala has more convenient size, not too many handling steps, and the process can be completed very quickly compared to Respimat. Patient preference contribute to treatment compliance and eventually on disease control. Although in vitro and in silico studies in favor of Respimat, if patients make critical errors such as our case study patient who does not turn Respimat before dose actuation, this causes no medications being delivered into lung. Patient may be considered for a switch to Breezala glycopyrronium, which costs less, room 82.40 for 30 days versus room 107.04 for 30 days for Respimat. Clinical response and side effects need to be reviewed after any change in treatment. If he still exacerbate despite appropriate therapy, good techniques and compliance, azithromycin 500 mg 3 times every week or 250 mg per day, or erythromycin 500 mg twice daily, for 1 year can be considered. However, the risk of development of resistant organisms should be considered too. Alternatively, roflumilast can be added if his FEV1 less than 50% and he has chronic bronchitis. Trials to de-escalate ICS can be taken under close medical supervision if lack of clinical benefit or side effects, like pneumonia, happen, especially those with blood eosinophil counts of at least 300 cells per microliter. The latter group has higher risk of exacerbations relapse after ICS cessation. Gold 2019 report do not recommend to escalate other agents. This patient was not prescribed any oral glucocorticoids because they do not play a role in chronic routine treatment in COPD due to a high risk of systemic complications against a lack of benefit.
As a conclusion, the choice of inhaler is dependent on patient's ability and preference, prescriber, cost and access. Treatment shall be personalized and adapted to the needs of patient. Here are a list of references that I had used. Feel free to further study them for more information. Thank you for watching Lively Life Snippets, and if you like my videos, hit the like and share button. Don't forget to subscribe and see you all in the next episode.